So first of all, we're going to talk about opioid use disorder. And I just want hands up who prescribe for my clients, for our clients, who prescribe methadone and buprenorphine. Okay, so for you, thank you. For those who are not prescribing, hopefully next time that I present, you all will have your hands up. It's one of the most rewarding things you can do with medicine. It actually works. It's a treatment that works. It's much better than prescribing antihypertensives for somebody who doesn't take them, or thyroid medications. We actually can see people get better. And that's a very, very rewarding thing. So please open your eyes and your hearts and your compassion and your perceptions, because I know, judging from the fact that you stay away from me, you're still scared. Okay. Now, I'm doing the last two sessions, so I'm going to try to keep on time, but please still keep me going. So we're going to talk about opioid use disorder. And this is a relevant topic, especially after the pandemic, when we saw an increase in overdoses. What do we know about this? We know it's a chronic, lifelong relapsing illness. And what do I mean by that? We mean that people who experience opioid use disorder might stop using opioids, but others might not. And what I know after working in the service for the last 5 years is that many people will on methadone or buprenorphine for the rest of their lives. I just been in Brisbane and I had the opportunity to put a long-acting injectable, to observe somebody in the nursing home having a long-acting injectable. And it was really rewarding. This person had managed all her life, had managed to work, and now she found herself with Parkinson's and is still opioid dependent. Addiction doesn't last a lifetime, but treatment potentially could last a lifetime. And I want you to have that in the back of your minds, because you might see clients, and I'm going to refer to patients as clients, because we in our service, we refer to them as clients because it's enhanced the self-efficacy. They are receiving our advice, and they're taking and they manage their condition with our advice. They're not waiting for us. They're not patients. They are clients. So we know the prevalence is growing, and the reason for that is because we are prescribing opioids for non-malignant pain. We also know that stigma is the main barrier for treatment. So we already, I want you to just go back to the first presentation about gambling and imagine that brain and how that brain was lighting with the gambling. And similar things happen with the opioids. And then when do that become a problem? We are inability to abstain. We have some behavioral control that is affected. We experience craving. So, oh, I need to take my pills now. Do I really have pain? Not sure. We administer, we don't recognize the problems. Maybe I just, I was a little bit sedated, but it was fine. And we know that there's a dysfunctional emotional response. And what do I mean by that? So I'm just going to go to this one here. And I wanted to bring that is because one of the questions that often we can ask clients is, do you ever use your medication at a larger dose? And do you ever use it because you're upset? That's that emotional response. Now, opioids were created and they're very useful. And they have allowed us to do procedures that we would never imagine to do and manage acute pain. But it also they allow us to manage emotional pain. And we have heard the importance of emotional pain at all levels all throughout this morning. Now, sorry. Any other questions, in terms of screening? They're there, but just have an idea how your patients or your clients take your medications. Do they take them more often? Do you have multiple doctors? Yeah? Speak to your pharmacist. Screening is the most important thing. Why do I think it's important to treat opioid use disorder? Because we know that the mortality is high. People can have accidental overdoses, especially in the elderly. We can have hepatitis C, HIV, liver cancer, cirrhosis, endocarditis. And very often our clients present that they're not treated, and nobody knows that they're using the opioids in a different way. So what can we do with somebody we feel that somebody's using the opioids differently? We don't want to start into in a confrontation or in a fight like, oh, I prescribed this and you took it differently. And often we can use these frames, which is a framework basically, that is feedback. So we do the screening, and then we ask about the patient's responsibility and your responsibility as a prescriber. We advise on how can we change things. We talk about we have to do it with an empathy and non-judgmental approach, and I think that's the most important part. Not judging people is the crucial thing to address opioid use disorder. We also want to build that self-efficacy. How can you function? How can you manage your pain? Or how can you manage your emotions? And where do we go from here? What options do we have? We can continue to prescribe those opioids, we can wean them off, or we can start opioid replacement therapy. So how many of you know what methadone is? It's kind of worrying that half of the people who know what methadone is are the ones working with me. Yes? And I think the reason for that, why I'm worried, is because this is a very relevant condition. And methadone and buprenorphine are very good therapies to manage this. The reason why they're good is because imagine you are in an island that continuously, with global warming, continually is melting, and you're having to swim to the next island to try to get sort of that safe space. Being on methadone or buprenorphine is being in a nice, safe island. I don't know if that's a good metaphor, but it's just trying to imagine that our patients who are dependent on opioids experience withdrawal, and that's very, very difficult to manage. It's not going to kill them like alcohol withdrawal, but it can cause a lot of discomfort and a lot of physical and emotional pain. And as physicians, we have to acknowledge that. What is our responsibility there? What can not, let's say I screen a client and she's taking, 900 milligrams of tramadol, like the case I'm going to talk about. What can I not continue to prescribe? And the reason is because the legislation and the Misuse of Drugs Act determines that we are not allowed to prescribe for dependence. And this is when CATS gets involved. This is when we want you to call us and say, what can I do here? And when we want you to speak to your clients and to say, look, I cannot continue to prescribe for you. You are prescribing for dependence. So we go back to the options for treatment. Just to say that naltrexone, which is an antagonist, is not funded in New Zealand. That detoxification or withdrawal for those who are severely dependent is not an option. Or potentially could be an option, but it's not very successful. The reason for that is because if we stop the opioids, what will happen to my tolerance? Decreases. And as my tolerance decreases, my risk of overdose is higher. So we actually increase in mortality if we do that in an inappropriate way. So you can just go and say, I don't prescribe it anymore, but that's not good enough. If you feel that you cannot prescribe for that patient, you need to speak to us and you need to make a plan. Because you potentially could put that client at risk. Now, let's go back to maintenance. We know that it works. Multiple studies continue to show that methadone and buprenorphine keep people in treatment. And what does that mean? That they are not seeking the next dose. They are taking the opioids to feel normal, and they continue with their lives. We know that it reduces mortality and reduces all the opioid use. So who I work for? I work for the Auckland Opioid Substitution Treatment Service. We are a harm reduction service. What do I mean by that? I'm not going to tell my clients to stop completely using everything. I'm going to meet them where they are, and I'm going to try to explore how they use the drugs. If I tell you when I was a trainee, I was going to ask patients how they injected drugs, I would have thought that I was crazy. But now it's one of the things that I often explore. How do you inject? Where do you inject? Do you inject in your neck? Do you inject in your femorals? So who gets referred to AOS? And this is important because, as many of you know, tramadol is now a controlled drug. This is data from 2017 from Dr. Gray. And so codeine, tramadol, and methadone, which is being used illicitly, and often get prescribed to our service. I want to highlight that pain is a big group of our population. Not all the patients with pain will go to OST, but they will benefit to being in opioid substitution treatment because they won't experience that withdrawal, and the pain might be better managed. In New Zealand, we don't have buprenorphine for pain, but they able to fund it themselves. So just to say that buprenorphine and methadone, so methadone is a full agonist. That means that if I'm using heroin and we put somebody on methadone, my mu receptor will be happy. Similar thing with buprenorphine. And naloxone are your antagonists, and this is important for later. So very much as I was saying before, methadone allows that client to not experience withdrawal. So just imagine you put, I don't know, your makeup in the morning that lasts for the rest of the day. And I think it's important that we destigmatize this. So we start patients with methadone. So let's say if you refer somebody who is injecting 200 milligrams of morphine, and we started on methadone, and they tend to stabilize between around 80 to 120 milligrams of methadone, and we dispense once a day. Why does it work? Because it has got a long half-life. We know that it achieves a steady state on day 3 and 4. And what we see is that people do get better and stop using other opioids, because what is the point? If my mu receptor is happy, I don't need anything extra. Okay, I'm gonna jump this. Now, buprenorphine. Buprenorphine is a partial agonist, and the benefit of buprenorphine is it acts without causing respiratory depression. So for those clients who want to be more alert, who want to engage with work, who feel that they want a more liberal regime as well, they do better with buprenorphine. Not all of them. It's a client choice. So when I see somebody, I give them the options. Remember that menu of options that I talked earlier? Methadone or buprenorphine. And this is just a slide that you can have, but just to compare the two. And they basically know there's no difference. And some people believe also, some studies have shown that methadone have better retention rates. But in my experience, I've seen very, very good results with both of them. Around the world, buprenorphine is used more frequently. And this is now more so that in other parts, in Australia, for example, they have long-acting formulations. What that means is I can have an injection weekly or monthly. Imagine not having to go and have a pill every day. So at the moment, clients attend the pharmacy daily, and once they're more stable, they can attend 2 or 3 times a week. And once they get to you, they might be on just once a week only. So this is just a case, just to highlight that so many people can use opiates and they cannot be dependent. So for example, in this case of Xavier, he's using home bake and methamphetamine at the weekend. Are we going to put him on OST? Hands up. No. He's managing to work, he's recreational. If he escalates his use, experiences serious consequences, stops work, we might decide, what can I do with Xavier? I want to talk about how does he inject? Does he use needle, attends to needle exchange? Drug harm minimization is what we need here. Now, this is a case, actual case, somebody who was started on tramadol, and I only got 1 minute left. And you will have this. So we need to have those discussions and focus on what was strong. In the case of Lori, she wanted to engage. She didn't want to use 900 milligrams of tramadol. She didn't want to have seizures. So what did we do? We talked about goal settings. Her goal was to stop using tramadol. We started doing limit her dispensing. She went to the pharmacy, and then she started on buprenorphine. Oh, sorry, I missed one, sorry. Okay, she started on buprenorphine, and she stabilized, and she's very, very well. One of the things that Lori asked me to tell you, and that's not her real name, is that she wished she had known about cats earlier, because she was prescribed tramadol for about 6 years, and nobody ever questioned that for that prescription until she had a seizure. So we need to talk to our clients. How do they use the pain medications? Okay, lastly, overdoses. We need to talk to our clients about the risk of overdose. It is increasing, and it's increasing because of polysubstance use. It's estimated that it's about 45 overdoses a year in New Zealand, and that could potentially increase with the new tablets that are available in the dark web, which are synthetic, opioids. This is a very busy table, but it's just to make you think about the factors that could influence the risk of overdose. So, your COPD patient, somebody who's drinking alcohol, somebody who is using benzodiazepines. Talk to them. Have you ever, fallen asleep and they have struggled to wake you up? Look at the discharge letters. I had a 23-year-old who was prescribed pregabalin for her fibromyalgia, and she was using morphine on top of that, and she had GCS of 3, and there was no follow-up for her until she engaged with cats herself. And lastly, just to say that you're able to get naloxone from our service. If you have somebody who is at risk, please contact us. They need to kind of be dispensed by the service themselves. But we got intranasal naloxone, and also that can be accessed in the pharmacies, if somebody is at risk. And the other option is the injections. Okay. So I hope that this has taken away the fear from the management of opioid use disorder. Now we're doing 3 months prescription, so you can take more of our clients. And I hope that now we can all help those who experience dependence on opioids and have addiction to opioids to enhance that recovery, to support the health. And this is from David Best, so the recovery model that is connectedness, hope, identity, meaning, and empowerment, which is some principles that we can all enhance in our clients. In conclusion, it works. People get better. People stop using other illicit opioids. Chronic pain and opioid dependence coexist. I hope that in the future we get long injectables that will kind of revolutionize the treatment for opioid use disorder in New Zealand. Thank you.